Great. So the question often is asked why a gynecological oncologist would present a talk on postpartum hemorrhage. But
that is a good question.
Often we are the ones who are called when there are dire straits and bleeding can't be stopped. So I'm an on-call person for a close by labor ward when things get hot. This is sponsored by Ethicare. I have a number of disclosures, but probably the biggest disclosure is I can't spell. So if there are spelling mistakes, I do apologize. So if you look at the South African Saving Mothers statistics, the most recent publication was that we look at the statistics over 4 years. In fact, obstetric hemorrhage came out third. Prior to that, it was the second leading cause of death in women who give birth. And it really is a travesty for a pregnant woman to die. So I'm going to concentrate my talk mainly on primary postpartum hemorrhage as opposed to secondary postpartum hemorrhage. This is a massive subject. You can speak on many, many things when discussing postpartum hemorrhage. There are many definitions from many societies, but for us, I think we traditionally taught that if you bleed more than 500 mils from a vaginal delivery or 1,000 mils after a cesarean section, that is considered a postpartum hemorrhage. And then obviously you can use a number of pictorial things in order to decide how much bleeding there is, because it can be catastrophic, rapid, and very subjective in the amount of blood loss. There are various protocols or checklists that can be followed. The labor ward that I cover has a PPH protocol, which says that anybody in the labor suite can call this a massive PPH, from the scrub sister to the floor nurse, the anaesthetist, that the surgeon or the principal obstetrician does not need to be the person to say, look, there's trouble. And we found this to be very useful, because often you're so caught up when you're doing the delivery, you don't realize how much trouble you're in. So I think it's a very useful thing to call the PPH protocol into being if it's happening. The most important thing is to be prepared and think ahead. Recognizing a placental accretor spectrum disorder prior to delivery is key. Often I get called where somebody is doing a Caesar, they open, and only then do they realize there's a placenta accretor or a placenta percretor, and they get into trouble, and then it's damage control, when in fact, if you had that in place and you knew that there was a placenta accretor beforehand, there are many things. First of all, you would probably deliver in a center that has embolization available. You would have blood on standby. You would have the cell saver. You would have a senior obstetrician with you, or a senior surgeon with you, or a gynecological oncologist surgeon with you, so that you can tie off internal iliac arteries, resect the colon if you have to, resect the bladder if you have to. So have a plan in place before you start is key. And then iron deficiency anemia. I want to mention a bit on iron deficiency anemia. The contribution of iron deficiency anemia to the risk of peripartum transfusion really, in a lot of literature now, has shown us that iron deficiency in a transfused woman is much higher than in non-transfused women. And in fact, this trial that was done in South Australia, there was a significant decrease in the rate of anemia at delivery and a decrease in red cell transfusion in anemic women, even if the number of PPHs remained stable. And I can tell you that 2 weeks ago, in one of our teaching hospitals, we lost a patient because there was no blood available. Blood is in short supply. So if we can address iron deficiency anemia prior to delivery, it would go a long way. We have some South African statistics. If you look at the prevalence of iron deficiency anemia across the board, it's approximately 40%. And women are particularly vulnerable and are as high as 56% of women have iron deficiency anemia. In 2000, they looked at pregnant women and they found overall 12%. But in this very recent publication from our department, we saw that iron deficiency anemia really in women less than 18 weeks was around about 30%, and 15% at 22 weeks and 36 weeks respectively. So I think in an area of high technology precision medicine, many pregnant women are surprisingly still iron deficient, and we are not adequately addressing this. So it behoves us to look at ferritin and an FBC and then adequately replace iron. And oral iron may not be sufficient. And in fact, we should think to giving intravenous iron, particularly in the second trimester in women that we find to be iron deficient. What about at the time of delivery? Tranexamic acid is a very versatile drug. In fact, I didn't realize that low-dose tranexamic acid is used for hyperpigmentation. I learned that the other day. But the effect of tranexamic acid administration in the woman trial on mortality, hysterectomy, and other morbidities was published in The Lancet in 2017. And it was a large trial that involved several women from both low-income, middle-income, and high-income countries. And if you look at the data, the forest plot, you'll see that the introduction or giving 1 gram of tranexamic acid at the time of a bleed, particularly early, in other words, it has to be given before 3 hours. So if you've been working longer than 3 hours, and then you say, oh, let me give the tranexamic acid, it seems to have no effect. And this is also true when they compared it to the CRASH-2 trial, is that early administration of tranexamic acid was predictive or better from a death perspective than giving it later. So why the time difference? Well, enhanced fibrolytic activity occurs and fibrinogen depletion occurs early in the stage of a major postpartum or traumatic bleeding. And so we should be giving 1 gram as a slow infusion over 10 minutes. A fast infusion, in fact, causes hypertension. If the bleeding still persists, you can give a second dose after 30 minutes. Its activity lasts 7 to 8 hours, and its effect on breastfeeding and in breast milk is unlikely to cause antifibrinolytic effects in the infant. So, in summary, the women's study reduced death due to bleeding by 19%. It reduced the incidence of laparotomy to control bleeding by 36%, but it didn't reduce hysterectomy. But when they went back and they looked at the data, they saw that at the time of giving the cyclocapron, the decision to do hysterectomy had already been made and the procedure had already started. So the data is not robust in saying that it would decrease hysterectomy. However, it did not reduce all-cause mortality. And if we look at the deaths that occurred in the developing countries, there were 483 deaths during the time of the trial. We noted that 72% of deaths were due to bleeding, and there were many other reasons for death, such as pulmonary emboli, sepsis, etc. But when they broke down those deaths due to bleeding, the vast majority of them actually occurred in Africa. And they thought that it was because women who delivered outside of the participating hospital were then transferred in, then randomized to be given the the tranexamic acid. And in many places, blood is often unavailable. in short supply. And in most countries in Africa, the relatives have to pay for the blood, and many of them could not afford the blood. So that was why we had such a high mortality rate. And clinicians in the trial highlighted that late presentation, maternal anemia prior to delivery, poor infrastructure are key contributing factors to death of these women. What about giving tranexamic prophylactically? Should we not be giving it at the time of cord clamping? So there have been some trials. There was this one that was recently published. It was randomized to 1 gram versus placebo at the time of cord clamping, and they did find a lower incidence in primary PPH and a lower incidence of mean blood loss, and this is at vaginal delivery. If you look at women who deliver by cesarean section, this meta-analysis included over 10,000 women, and they certainly found a lower total blood loss, a lower hemoglobin drop, a reduction in the number of additional uterotonics that were used. But interestingly, the subgroup analysis indicated that there was a much greater effect in lower and middle income countries compared to the first world. But there's no mention of safety data, and we really do need further studies. My criticism is that in most places, if you add it, in other words, to your armamentarium at the time of delivery, is most women do in fact not have IV access if they're going to have a vaginal delivery. So, we don't routinely use intravenous drugs in delivery. So maybe we need to look at doing a trial on administering oral tranexamic acid, perhaps, when somebody is 6 or 7 centimeters dilated, to see whether that would make a difference. So there is a trial that can be done. What about the economics? Is it going to add a lot of cost? So there was this TRAP study where they looked at cost, and essentially what they found was that it didn't add significantly to the cost of delivery, and the probability of it being effective was greater than 60%, but less than 80%, suggesting that it might be a promising, modest cost drug for achieving a reduction in complications from childbirth. So the next thing I want to move on to is selective embolization. I'm fortunate that I work in a hospital where we have high-tech intervention radiologists. My hospital does not, however, have a labor ward, and the labor ward down the road does not have an intervention radiologist. So therein lies some of the problems. So selective embolization is certainly an emergent way of managing postpartum hemorrhage. And this is a fantastic systematic review in ONG survey that was published now in April this year. And they found—
We've got 1 minute, if you could just bear that in mind, please. Thanks.
That this was technically a successful thing to do. So the worry is often fertility, and there does seem to be a decline in fertility post. So I just want to finally say, don't forget the Bakri balloon. This is a balloon that we use and insert, and it causes pressure. And then surgical compression sutures that can be used at the time of postpartum hemorrhage. And finally, to say that systematic occlusion of blood vessels. If you tie off the uterine artery, you decrease the blood supply. If you tie it off bilaterally, you decrease the blood supply to the uterus by 80%. So you can significantly reduce blood loss by doing systematic devascularization. And just to say, call for help early. Don't let the patient decompensate. Watch out for the anemia and replace iron antenatally. Make sure you have tranexamic acid on hand. We use the cell saver a lot. Put the patient into Lloyd Davis so you can see if bleeding continues, and use other modalities. And often don't err on caution. Do a hysterectomy if it's going to be life-saving.
Thank you very much indeed, Trudy. Short and to the point as always. Thank you for your time and a beautiful presentation.